No, but then what'd you say?
Of care. I said venues, today you said settings.
Oh, okay. Venues are settings of care. So basically different areas you can work in as a PTA. So I decided to start at the very beginning in acute care, the first line where you patients will come in and experience PT or have a PT or PTA for the first time. So some of you have worked in acute care. What type of patients do you usually see in acute care?
All strokes, trauma, surgery.
They can be all different kinds.
Ask Jeff. Ask
Jeff doesn't even know what acute care is.
He said, you looked at him,
Old, young.
you looked at me, you said,
Right.
He's red
He
too.
said, bad ones.
And that is true. More critically ill patients, right? So acute care is good for variety. Like you said, there's a variety of patients. Like Robbie said, old, young. You can work in a pediatric acute care. You can work in a NICU with babies. You can work all the way up to geriatric. They have all different medical problems. Good and bad things. Length of stay. How long do patients usually stay in the hospital?
It depends.
A couple days. Unless they're critically ill, they may stay for weeks. But most of your acute care patients are going to be 3 days, maybe a week if they're really bad. So that's good and bad. You don't get to see how they progress, but if you don't like them, they're gone. You usually only see the patient. What?
I just want to add something.
Oh, what?
I just read an article last week, that's the reason why. Average length of stay is 2 to 4 days.
2 to 4, yeah.
When you combine all like diagnosis and stuff like that.
So that's
And then they even broke out like knees stay this long, hips stay this long.
and that's getting shorter and shorter.
CVAs stay longer than ortho patients.
And you can't even work in ICUs where people are going to stay for even longer. But how often do you see your patient in acute care?
Daily?
Once or twice a
Couple
day.
times a day?
If you're doing elective surgery, you want to see them 2 times
A day.
a day. And then if they're not elective surgery, like a stroke or a back order, you just see them once.
A day.
Mhm.
How about some other people?
Also, if you have outpatient in the hospital setting, then you need to see them when you have availability. So they may not get seen every day that they're there.
Oh, wow.
That's just an E.
I was like, I've never heard of that. Well, and sometimes you don't see people every day. Like a lot of patients, if they're pretty low level, they came from a SNF, they're going back to a SNF, you see them twice a week maybe. So the stays are different lengths too, or the amount of times per week you see them. Some good things about acute care, different, not talking about actual patient care, hours, you can usually start pretty early, 6:30 or 7. You can work pretty late, 6:30 or 7. So it works for your schedule. A lot of times you can be more flexible with your schedule. Some people like to work 4 10-hour days. Some people like to work shorter days, or sometimes you need a break in the middle and then you can come back and finish later. So the schedule can be more flexible. If you're in a hospital setting, you always have to work holidays, weekends, all that kind of stuff. So sort of lifestyle things to take into account too in the different settings. The other thing is in acute care, what I feel like, and you guys that have worked there can tell me if you felt this way, I feel like it's your medical knowledge is very important. Checking lab values, checking oxygen saturation and blood pressure and all that stuff. So in that setting, more than in an outpatient setting where someone's more medically stable, these people are not. And so you really have to be paying attention to those kind of things a lot more than in different settings. Another thing in acute care is communication. You have to communicate with everyone. Your other physical therapists, physical therapist assistants, occupational therapists, speech therapists, doctors, nurses, social workers. You have to call people on the phone. You have to page people. So there's lots of communication throughout all disciplines when you're in acute care. So it's an exciting setting. And I think one of the fun parts for me, at least, was having to have the more medical knowledge and understanding what was going on that way. So, any other thoughts or anything? Acute care?
Not really about acute care, but whenever I was in my clinical, I heard that in the next 10 months, they're going to start doing knee replacements in outpatient.
Wow.
Yeah, I read that.
That's crazy.
I'm a lover of acute care. One, because I can't stand waiting on people, and I hate for people to be late. Imagine that. So it was always when I was an outpatient. You know, my 8 o'clock would show up, my 9 and 10 would not, my 11 would show up, and then run late into lunch. My 1 o'clock would come early. My 2, 3, and 4 would not show up, but my 5 o'clock would. So it's
A lot
kind
of
of
that.
like, but we're on productivity. So that was one reason why I didn't care too much for outpatient. I like the patients. So my love became orthopedic floor. So knee replacements, hips, stuff like that in acute care. You have to be very creative in acute care as far as wiping the butt, stuff like that. I can honestly say I hardly ever did wipe a butt because I was pretty creative of how I didn't have to. I also believe in if you had knee surgery, your hands still work.
Oh,
so
yeah.
the patients do it themselves. But I really like the flexibility of acute care.
I think.
And PTAs can wear more hats in acute care because you can get pulled to outpatient, you can do management stuff, you can do student things. It's actually very rewarding to be able to market yourself. So,
She meant like have more jobs. I mean, or do more things. Oh, I meant like a hat.
we're like,
Roll, Lord. All right. So after acute care, if you're in the hospital and you're sick, where do you go when you leave the hospital?
Home health, the outpatient,
Home health,
or a sniff,
a sniff,
outpatient,
Inpatient.
outpatient,
or the subacute floor.
yep, subacute, and where was the other one? Inpatient rehab.
Yeah.
Favorite color, Mark?
Listen,
Or to the morgue.
That's what we said, we said heaven.
that is another place you can go.
If you get there.
Or heaven.
So all different places you can go from there, right? So what's subacute?
daycares, sorry. Daycares are becoming,
That's like home, right?
it's where you take someone to a daycare for the day. It's
Like adult daycare.
Like the senior centers.
But that's kind of like outpatient-ish. Or school. So, what's subacute? Or sometimes it's called long-term acute care. So what it is these people that are not doing so hot, they're really, really low level. They're not medically stable enough to go to a SNF or an inpatient rehab. They can't tolerate an inpatient rehab, but they're not even medically stable enough to leave the hospital really. They still have a kind of acute hospital needs. And so subacute, I know at Cone there's a level called select and it's on the 5th floor. And those are subacute patients. So maybe they don't need doctors rounding every day, but they need it more than once a week or something at the nursing home. So these patients are pretty low level. They probably had a long ICU stay and hospital stay, and it's still almost like acute care in the hospital setting. It's just more long term. So those patients might stay there for a week or a month, whereas in acute care it's going to be 2 to 4 days. So these are pretty low level patients. A lot of just getting them sitting, maybe standing, not going to be doing a lot of walking and all that stuff. All diagnoses, usually very debilitated. I mean, you're not going to see total knees and stuff there unless something else happened, or they had heart failure and horrible strokes and all this. So subacute is like a continuation of acute care when they know they're not going to be able to transfer you somewhere else in a short enough amount of time. And so, but your needs aren't good enough that you're stable enough to go to a SNF. You might be on a ventilator, all that kind of stuff.
When I was at my SNF, they said that because of the way Medicare and Medicaid and everything are changing, now they're gonna start seeing more severe patients. Like,
So, within
or-
SNFs.
yeah,
Wow.
which actually we had, maybe the last 3 weeks out there, we had a good number of people who were more.
Acute. Well, a
and
lot
I
of,
mean, they'd end up going back to
The hospital a lot.
But just because they're trying to shorten down
and that's another thing.
stays in the hospital.
A lot of, some nursing homes won't take people if they have to be tube fed, They won't take them if they're in fail beds, which are restraints at all. So maybe now they're gonna start making nursing homes take more of those people, but either way, they're still not really medically stable. So it's more complex medical patients, same thing as acute. Same thing as far as flexibility of hours, times, days of the week, still working on weekends and holidays and all that. Another place you can go to is my personal favorite, inpatient rehab, which they have those in hospitals. Also, there are freestanding ones. The patients still get seen by a doctor every day, but they're stable and healthy enough to tolerate 3 or 3.5 hours of therapy every day. So that's a lot of therapy. Yes.
So, my last day out at home, I heard that there's not like a quota of patients that you really try to have to see in inpatient, as versus acute. Acute, you try to see like maybe 10 or 11 patients within the.
You have to do a certain number of hours of therapy a day on rehab.
Okay.
So like you work an 8-hour day, you're expected to do 6.5 hours of therapy.
Okay.
So does that make sense? So it's not, because sometimes you see like brain injury patients, traumatic brain injuries have to get 4.5 hours of therapy every day. Now that's OTPT and speech, but still I'm seeing that person for 2 hours easily by myself. So that's only one patient, I guess, but I'm with them for 2 hours, which is a lot longer than 30 minutes that you're with them on acute. So it's not a patients per day, it's an hours per day. We still have productivity standards.
Right. Okay.
So that being said, inpatient rehab, you have to see patients 3 hours a day, so you're with the patients for a long time. Average length of stay is about 2 weeks. These patients they're mostly neuro, amputees, debility. They have inpatient rehabs for both pediatrics and geriatrics. I think in North Carolina, Charlotte is the one that we would send most of our pediatric patients to. And usually this was like 16-year-olds, like right at the verge of pediatric. But code one is just adults. But you do see more younger patients. Usually work as a team with an OT and a speech therapist, so you all work together, coordinating care with nurses and doctors. Like I said, you don't see as many orthopedic injuries. Usually, you can't even go if you just have a single knee. Sometimes we'd see people with 2 knee surgeries or someone that had a stroke while they were having a surgery or something. But most of the time, it was more neurological diagnoses and amputations, debility. So you still need a little bit of your medical knowledge because the patients still aren't completely healthy, but I guess less so than on acute care. They don't change as much every day. So, and you can still have patients with feeding tubes and all that stuff, whereas unlike a lot of times SNFs won't take those patients. Questions? It's the best.
I got one more question.
Yeah.
Is there a difference in pay between the acute and inpatient?
In the hospital, cone will pay you the same regardless. Like cone just pays to whatever, so it's not a difference. So then SNF, a lot of you have been to SNFs. What kind of patients do you see there?
Geriatrics,
Geriatric usually.
post-surgical. They can't go home taking themselves.
Yeah, and you can see single joints there, just somebody had a knee.
People who don't have anyone to look at after they're home.
That's a lot of it, because people don't.
There's a lot of balance.
So most of the
Respiratory
patients
and
we
heart.
had were UTIs.
Just confused?
A lot of general weakness.
Yeah, generalized weakness. A lot of people that we would see in the hospital and we're like, you probably shouldn't have been living at home before.
Yeah.
But like now that you're here, we're definitely not gonna let you live at home. Like I feel like that a lot when I see those patients. Like they probably shouldn't have ever been at home, but like I'm not signing my name to the thing that says you can go back and do whatever you were doing. I feel like that a lot of SNFs. But there's lots of balance problems, joints. SNF can run anything. Amputees go to SNFs. A lot of people go to SNFs. Debility, generalized weakness. How long do you stay at a SNF?
Depends on your insurance.
Money, how deep your pockets?
That's true. A lot of times it's like 30 days or 31 days. Or how much Medicare pays for 100 days? Is that right?
Yeah.
And then the goal of a lot of more of the rehab SNFs is to get them home, right? Like if you just had a knee replacement. Some places are more long-term. It's very difficult. Like Tiffany was mentioning, adult daycares, I know we have a lot of issues like, okay, a brain injury patient, that takes like a year to get better from, right? So they may stay at inpatient rehab 4 weeks. Then, okay, they can go to a SNF, which is weird because they're like 20 years old. And they're at a SNF, they get 100 days, but they still have half a year, and then what? You know? So it's hard. It's hard, and those patients, that's hard. Yeah.
So like where I was at for my first clinical was a CCRC, and they have like outpatient, and then they have inpatient, then they have long-term care.
Yeah.
Can you stay at long-term care like as long as you need?
I
or
think
is
long-term
that-
care is just, yeah.
Okay.
But you don't get therapy necessarily in long-term.
We did.
Yeah, we did.
We did therapy.
So they
in
can pick
long-term.
you up on therapy? Okay.
They can pick you up, but it's not like everyone just gets it.
Right, whereas on
Right.
the rehab part of a SNF, everyone's getting therapy.
Yeah.
And you still have a number of minutes you have to meet in SNFs if you're in the rehab part. So kind of like inpatient rehab, there's a number of minutes. It's not as many in a SNF, but you still have a certain number of minutes you have to meet. And with both of those, SNF, inpatient rehab, like we've been saying, you're gonna work every day, holidays, weekends, all that kind of stuff. But there is flexibility in the schedule and the hours. You can come in earlier, you can come in late, stay later. A lot of people work 410s or something like that. So all these are pretty flexible schedules. Inpatient isn't as flexible because when you work in inpatient rehab, your patient has a schedule because you have to coordinate between the speech, OT, PT. So you kind of have appointments even though they're not coming to you. It's kind of why I loved it because like Tiffany, I hate when people don't show up. So like I know where my patient is, they didn't escape. So so when I have an appointment, the person's there, I get them, they know it's my time and we do our thing. So I like that. But not as flexible, whereas a SNF you can go see who you need to. Lots of jobs in SNF, lots of money, more money in SNFs. If you work at SNF. Home. Few of you had home health clinicals. What types of patients are there?
Oh,
All of them. Joints, yeah, post-op, anybody, right? As long as their family can take them home, they can get therapy at home. So a lot of people that could be at home could have also been in a SNF if they didn't have anybody to take care of them. You do lots of, all different types of therapy. Things about home, you're alone, right? So you don't have resources around other therapists, people to ask questions. You don't have a doctor or nurse, at least at a SNF, there's always a nurse if something's going on, you could ask, you have to call, there's something going on. So your patients are more medically stable, obviously, because they're allowed to go home, but it's more important to check on those things. Did you take your medicine? Have you had a change in medicine? All that stuff. How often did you see your patients in home health?
Like 30, you talking about like a day? Or
Yeah, how many days a week?
They were like
3,
twice.
2 or 3?
Yeah.
And how long?
It was like 30, 45 minutes.
Okay, and then how long did they stay in home health? Like, is it like a week or 2 or a month?
Well, I know one person, he was there for about 3 weeks, and then he was not ready to go.
I feel like that's probably about normal. Yeah, the goal of home health really is to get them to be well enough to go to outpatient, if they can get transportation, all that, which is hard. But yeah, so I'd say like 2 or 3 weeks, see them a few times, and then hopefully transition them to be good enough to go to outpatient. Home health is very flexible. I've heard it's the best. I've never worked in home health, but I've heard it's the best as far as flexibility because you make your schedule, right? So like if you have a doctor's appointment, you just move your patient around. So that's nice. They do try to work weekends, holidays, all that same thing. So everything so far you're working weekends, holidays. Until you get to the cush life that Jeff leads in outpatient. So outpatient, a lot of you have done outpatient clinicals. What types of patients do you see there?
Young, old, middle-aged, everything.
I would say all ages, yep.
Athletes, geriatrics.
Orthopedic and neuro, right?
Vestibular.
Vestibular, yep.
We got infants.
I say everything else pretty much.
Kids.
Babies. So pediatric, you can see any age range, right? They're obviously well enough to be home and they can get to outpatient. This is where you're gonna see most of your higher level athletes, all that stuff. Higher level anybody, able to take care of themselves. So you finally get to stop wiping butts, maybe, hopefully. Outpatient can take place in many different forms. You can have a freestanding outpatient clinic. You can have one attached to a hospital. They can take place at adult daycares, where they go to daycare all day, just like a kid. You guys know about school system, same thing, that's kind of like outpatient therapy. They're not home, they're at school. There's aquatics, that's part of outpatient. Large variety here. So when I said in acute care, you really need that medical knowledge, lab values, all that stuff. What's most important knowledge kind of an outpatient?
Anatomy.
Anatomy, that's exactly what I was gonna say, kinesiology, anatomy. That stuff is way important. I don't remember a lot of it because my people have bigger problems than range of motion, right? But in outpatient, that's where you're gonna get, I feel like that's where the technical physical therapist assistant brain kicks in and you're really thinking about origins and insertions and muscle testing and goniometry and all that stuff. So it's a lot more detail oriented than some of these outpatient home health where it's big picture and you're just like, let's get out of bed, let's walk. I'm not worried about what your gait looks like necessarily yet, right? I'm worried about if you're just making it from point A to B without falling over. Then when you get to outpatient, you'll clean it up. A lot of times when I work with stroke patients in inpatient rehab, I'm like, yeah, you're walking, you're able to walk, like you're pretty safe. And I always say they'll clean it up when you get to outpatient. So outpatient's a lot about cleaning up, making things more efficient, joint movements. Outpatient is probably the least flexible, right? Because you have a schedule, your patients are coming, you gotta be there. Like Tiffany said, if your 2, 3, and 4 cancel, you still gotta wait because your 5 o'clock's gonna come. And it's always your 5 or 6 o'clock patient that's gonna come. So it's less flexible that way. You don't have to work weekends, which is nice. Some places you do. Jeff's works on Saturdays, but some places you do, and you usually don't have to work holidays. So you get those days off, which is nice. If you're into that. Hours are still the same. Most places you can work. Pretty much being a PT, you can at least work 7 to 7 somewhere, like somewhere within that range. Places will be open. Not every outpatient place is open, all that, but they're different. I worked in outpatient orthopedics. Like Tiffany said, I got frustrated because people don't come. It's annoying. I did a lot of workers' comp, which is a different kind of thing. You can get into ergonomics, like Tiffany said. What other settings are there that I didn't talk about? Peds, school, peds. All these peds can be at an outpatient clinic, right? Peds can be home health. Peds can be at an inpatient rehab. Peds can be in acute care. So peds can be in any of those different categories. It's just which one you want to work in. I think around here, does Baptist have like a neonatal specialty? I don't know. They have the
I think they're doing Brenner's, yeah.
Right?
Yeah.
So Brenner's has a special hospital, so they have all that stuff for peds, all those different venues for peds. Like I said, we always send ours to Charlotte, our younger kids. I wish in my heart, knowing there's so many spinal cord injuries and brain injuries that happen in 20-year-olds, and you don't want to send them to a SNF, right? Like, SNFs are mostly geriatric people. So I wish there was somewhere like that they could go for people like that. That's one I wish I could invent it. And there are a lot of like adult daycares, or there's even like, not like a camp, but like a camp where people can go, but those are few and far between. And they're all nonprofits, and they don't have it. But that's something I like. I've worked personally in acute care rehab, inpatient rehab, outpatient ortho, and aquatics. So I liked them all for different reasons.
What's your favorite? That was always inpatient.
It's like a drug. Love it. I like the teamwork. I like working in a team like speech and OT and PT. And I'm a big picture person. So I like the big picture as far as instead of the nitty gritty details like outpatient. I'm more of a big picture person myself, so I think, and I like crazy people, which, I mean, it makes it fun.
Yeah, that's crazy.
There's a lot of crazy people. so. I think it's fun.
Do, like, say at like a hospice house, do they normally have somebody contracted to come in, or do they normally have a therapy?
I would almost guess that they probably have a contract, but it might not always be, but they do hospice therapy, PT. I've never done it. Obviously, it's gonna be a lot of just positioning and range of motion. I think that would be sad.
I think Tiffany said that she had done it once.
Hospice. Whenever I get the patients that are like, have been palliative care consults, I just leave them alone. I figure they got other stuff to do. Well, like, especially if they just got that, you know, like, they're just moving to palliative care, I don't wanna.
Well, that's what we were saying.
I'll check on them and just say, hey, I just came. And they're like, yeah, I'll stay here.
We were seeing some of those people in the snow.
Palliative? Okay.
And people on hospice. And
Okay. Yeah, that's tough. But, any other questions? Comments? Good. All right. I think